Well, good evening. I think we're going to go ahead and start this webinar. We know a lot of people are still logging in, but we want to welcome everyone. My name is Jim Benenati. I'm an interventional radiologist from Miami, Florida. We have two other panelists tonight that you'll be hearing extensively from. Frank Arko, vascular surgeon from Atrium Health in Charlotte, and Dr. Jay Mathews, interventional cardiologist from Benenati Memorial Hospital. This webinar is sponsored by Penumbra. We're thankful for them for giving us the platform to share our thoughts and ideas with you and to also hear from you. And we encourage you all to chime in with questions. We have opportunities. We can answer all your questions. There's a lot of webinars going on right now. We're obviously in unprecedented times. This webinar is really designed to talk specifically about endovascular life in the hospital in all three specialties among people who are practicing it every day. So we don't have any international faculty. We don't have anyone really from industry. We're not talking about products and anything else. This is really kind of on the ground, grassroots webinar to just hash out some of the things. We may have a lot of suggestions. You may have a lot of really great ideas. So I think this opportunity allows us to interact and we hopefully can all learn from each other. So I wanted to welcome the other two panelists and maybe just start out, and we'll ask Frank and then Jay, just tell us for a second or briefly about your hospital, how big it is and what exactly is going on there. And we'll rotate around and then we'll come back and get into some more meaty questions. So Frank, tell us what's going on in Charlotte and the size of your hospital, your work environment.
Yeah, so work environment right now is clearly changed a significant amount. I work at Atrium Health. It's one of the largest healthcare systems in the U.S. We're a group of 11 surgeons, vascular surgeons, in a group that's Sanger Heart and Vascular Institute's got roughly 90 cardiologists within that group, and probably about 8, 9 cardiac surgeons, and then 3 pediatric cardiac surgeons. We work really out of 3 main hospitals in the Charlotte area. One's basically 1,000 beds. That's the one that I work in. We have one that's about 30 miles, maybe about 25 miles north. It's got about 600 beds. And we have one that's about 8 miles south of us that's got about 450 beds. And that's where we are right now. And that's a system that I work in. We certainly have undergone a lot of changes. I think we as a system have done a very nice job of instituting changes quickly for where we are right now.
Okay, Jay, tell us about Benenati Memorial.
Great. I'm Jay Mathews. I'm an interventional cardiologist. I'm the director of the cath lab at Benenati. Benenati is a smaller community hospital, about 450 beds. We also have a sister hospital down the street, about another 150 beds as well too. Primarily a lot of endovascular work being done in both facilities as well. We also have another hospital down the road that we do participate in as well too, which has another 250 beds.
Great. And our hospital is about an 800-bed hospital. We're an interventional radiology group that is really multi-specialty. We have 5 vascular surgeons and 8 interventional radiologists and 2 neurointerventionalists. We have obviously, probably like the others, a number of ARNPs and PAs, and we actually cover 3 hospitals and provide IR services to 5 hospitals via transfer and this type of thing. So let's kind of go around, Frank. Since this whole thing has come up, can you tell us a little bit about what your group is doing, how you've prepared for this, where you've been, how long things have been going on, and what the environment's like with the what's going on with COVID right now in your hospital?
I think we took a very proactive approach to managing this. I would say that probably 2 weeks ago, we as a group of vascular surgeons, because there are just 11 of us, really instituted 2 teams. We really go out to about 5 hospitals, but we cut that down to 3. We've got so really a total of 2 teams at each of the 3 major hospitals. The ones on the outside, they have 2 vascular surgeons there and the appropriate number of PAs and nurse practitioners. We dropped that down to basically having one vascular surgeon being present there at a time. At each of the two sister hospitals. In the main hospital, we really dropped it down to 3. We didn't change the call schedule because if you come in at night, you're basically away from the entire team, so it sort of keeps you safe. We completely 2 weeks ago shut down for the most part all elective cases. So last week, I personally moved about 6 patients that I deemed were could wait. I put them out 6 weeks. Whether or not that's going to be enough time or not, we'll have to wait and see. We shut down our entire outpatient venous program last week as well. We've gone to, I would say last week, we went to probably 90% virtual visits. We scrubbed our clinic schedules, deemed those that were sort of under routine surveillance to just either reschedule their ultrasounds 3 to 6 months out. Those that we thought were high risk, they got their ultrasound tests. If there was no changes, we just called them on the phone. And we instituted a certain number of essential cases that we thought that should be done, but we sort of changed some of the criteria for those. So for instance, we changed the criteria for elective aneurysm repair from basically 5 or 5.5 up to 6.5. Unless they're symptomatic and or rupture, we would certainly treat those. So we've done that with all the APPs. We as vascular surgeons saw clinic out of 5 different sites. Our cardiologists saw them out of 20 sites, but we changed any patients that we deemed necessary to be seen in person down to a total of 5 sites. So as a group, the whole institute, 20 down to 5 for vascular surgery. We saw it 5, but we really dropped it down to 3 in-person sites.
All right, so some pretty drastic changes there. And in a few minutes, we'll get into some specifics about these procedures. Jay, what about in your cardiology practice? What are you guys doing with your rotations, call, and that type of thing? And what's happened with your volume?
Well, I mean, obviously, we also have enacted pretty dramatic measures as well, too. Partly because we have COVID patients here in the hospital and also in the community. Right next door in Tampa, they have a large number of COVID patients. In our county, we have about 25, and there's far more rule outs than there are all actually positive patients. So, because of that, we've had to enact pretty drastic measures. It's actually an evolving process because, even as of today, all of the patients are masked, and we're screening every person that's coming into the hospital through essentially a single door. So we've had to enact some pretty, some might say draconian measures, but they're necessary to permit the isolation. In terms of teams, we've essentially gone down to 2 teams in the lab during the day. We have a separate night team as well too that we enacted and maintained. We also still have our separate call team as well too. So that way, if a shift does get infected or exposed, we're able to, potentially take them out of the rotation and not take out the whole lab in the process. So we've also used the process of trying to bring these patients down to a separate holding area while we're still trying to figure out whether or not there is a risk of exposure or not before bringing them into the main cath lab themselves. So all of these things obviously have reduced the workflow a little bit too, but since we've reduced the number of elective procedures, as Dr. Arko mentioned, it's really helped maintain a pretty smooth process overall.
So that's great. In our practice, we've gone to we started about 10 days or 12 days ago with teams where we cut our IR teams in half. And what we're doing is we're working 7 days on, 7 days off. So we have a week out of the hospital, a week in the hospital. We've reduced all the elective cases, but we're still doing a reasonable, not a lot, but a reasonable number of outpatients because we do a lot of cancer work. And patients who have recently diagnosed cancer and things like that, really need their treatment, and some of them need aggressive chemo and this type of thing. So we're still seeing that come in. But as far as virtually everything else elective is gone, and we have seen significant reductions in our volume. We actually have 2 people on call. We have a backup call in case there's a big case. We have the availability to bring someone else in, and I don't know that we'll ever need that, but on some of And one thing I'll ask you guys, the recommendations for how you prep and how you get ready seem to be changing. So a week ago, everybody would need a bunny suit and really a very elaborate setup. Now the recommendations are, an N95 mask and a face shield. So when we thought that it would be a very complex thing to get gowned and to doff, we actually had 2 people available, but now we're seeing that they've relaxed these standards quite a bit. And I'd like, one thing I'll ask you guys, one of the things that concerns me is I think some of the reasons for relaxing the standards are because of lack of availability of equipment, not necessarily based on data for safety. So we haven't run out of anything yet, but there's a definite shortage in our hospital of masks, of gowns, of N95 masks, and we're hanging in there pretty well. But we know that there's a shortage, and we have, we're trying to limit the number of gowns and things. In fact, we've eliminated having our trainees from scrub in on certain cases just to save on gowns and equipment like masks. Are you guys doing anything like that? Does anyone have any concerns about their inventory in their hospital? Jay or Frank?
Yeah, I mean, we have about 2 weeks left before we're going to have a severe, extremely restricted product available. So it's about a 2-week supply. Before, they were encouraging all of us to do PPE in all of our cases. We may need to enact what they've done in New York as well too, or for some cases where they're not using PPE if there's a low risk for COVID. I hope that it doesn't come to that, but unfortunately, we may have no choice.
Frank?
Yeah, we've been asked to wear masks when we come within 6 feet of patients now. They want you to try to wear 1 mask per day because of the fear of running out. I don't know what our overall length of PPEs are. We've been asked that if you have an N95 mask to basically put it in not to touch the front of it, and then to put it into a Ziploc bag to sort of keep it clean if you're required to use it. So that's where we currently are right now, but they're asking all of our individuals and our nurses who are taking care of really any patients to wear a mask now in the hospital, which is new from yesterday.
Yeah, so Frank, that's a great point. This is evolving, and Frank and Jay and I were talking offline before we started, and I think we all kind of agreed that if this webinar were 48 hours ago, we'd all be saying different things. And unfortunately, I think if we did this webinar on Monday, would say, man, what were they talking about last Thursday? And a lot of that has to do with changes in policy and resources. So it is a constantly evolving issue. One thing in our hospitals we're having a big problem with is, and I know this is very different for different faculty here, so I just real quickly we can touch on this. Right now in our hospital, turnaround time on testing is 4 to 5 days. In fact, I can tell you one of my family members, my wife's a physician, she's quarantined. She got tested last week. We still don't have the results. Do any of you guys have same day testing, and are you testing large numbers with that? How's it working in your hospitals, guys?
I can tell you right now in our facility, we have patients 8-9 days out still waiting on test results. It is possible for patients very high risk to potentially get turnaround time within 48 hours, but that reflects a very small number of patients. In the community, obviously, it's even longer potentially.
Frank?
Yeah, we have testing centers in place. I'm unsure of the amount of time or the turnover to get the results. I just had a meeting about this COVID about an hour ago, but the numbers all changed so rapidly. I think that the ones that they're testing, about 10% or so are turning up positive for the ones that they have tested. I think in the county that I live in, I think there's about 200 patients with COVID-19. I think in North Carolina there have been 3 deaths so far, 2 of them within the counties that we serve.
So let me ask you guys a question about this. In our hospital, we have a large number of PUIs, I think I think over 300 right now, and we have several positive patients in our ICUs, and we have actually 2 complete wards for positive patients. And we just took in there's cruise ships coming into Miami. Everybody's watching this like with keen interest to see where they're going to go. But in your own practice, what procedures do you do that you are the most worried about? And we all do similar stuff in the arterial system, but we all do a lot of different stuff too. So let's just touch. Jay, why don't you start? Are there any procedures particularly that you're doing that you're worried about, or are most of your procedures endovascular and you're kind of comfortable with the standard gown and prep, or what would it be that you're most worried about?
I'll answer since you lost video, if that's okay, Jim. I would say that one of the things that I'm concerned about that.
Yep.
Oh, he's back.
Oh, there we go. So right now I'm actually doing a lot more cardiac than I've ever done before. I mean, obviously I'm a primarily endovascular guy, and a lot of these patients that come in with STEMIs who are very unstable, they're in shock. They're the ones that are putting up a lot of aerosolized material into the air. So we worry about those patients' proximity. If you do a lot of radial access as well too, then it can be a little bit of an issue. So I do worry about some of those cases, especially those patients that are not intubated. Maybe we're going to intubate them during the procedure, and that's known to be one of the highest risk type of things you can do to these possible COVID type patients. So I don't really worry as much about the endovascular procedures, especially if I'm doing a foot procedure. I'm as far away from the head as possible. But when we're doing these other types of cardiac procedures, especially STEMIs and whatnot too, those tend to be a little bit more dicey.
There's never been a better time for pedal access than today.
Right.
So Frank, what about in your place? What do you worry about in your practice?
Right now, I'm not worried about the current procedures that we do, again, because for the most part, we're only doing essential procedures, and that's really urgent or emergent cases. One of the things that we do as vascular surgeon, it really doesn't have to do with endovascular, but I may sort of switch it to endovascular, is we do most of the ECMO decannulations within the hospital. And my fear is that a lot of these patients are going to be on ECMO, and then when they're able to get off, we'll be the ones sort of basically operating in there. So we normally make cut downs, but I had a conversation with a cardiologist today that we may very well change our practice, and it's not really changing it that much, but a lot of times in TAVR world and even in TVAR, EVAR world, where we've done something percutaneous and we've got a failure of the closure, we will now just fix those with an endovascular means, basically covered stents within the external iliacs and common femoral arteries. There's been some data to demonstrate that those usually work out pretty well. They're usually pretty normal vessels, and the patency rates of those grafts are pretty well. But I've sort of thought about either having these patients have the cardiologist or whoever's putting in the ECMO devices, and it's not always cardiologists. Sometimes it's critical care physicians. So there was a discussion about pre-closing a lot of these groins, which is fine. But if you don't know that you're in the common femoral and you put it in the SFA or the profundo or the external iliac, and then we have to go and operate because your closure has failed, then it makes it even a more complex procedure. So I've sort of said that we may proceed with fixing these or decannulating these with an endovascular means to try to limit our exposure to the virus, which, as Jay said, it can be quite high in operating rooms.
Yeah, that's very interesting. You know, in IR, we have a wide scope of practices, and I, like you guys, I'm not too particularly worried about the arterial cases. The cases that worry me quite a bit right now in our practice are some of the mundane things like G tubes and GJ tubes, because we have to put NGs in patients. It's essentially intubation, nasal and oral intubation. And the other procedures that worry me about are thoracic procedures, pleurex catheters, thoracenteses, lung biopsies, because those patients are coughing constantly when you tickle the pleura. So those are the patients I think that we're being the most careful in. In terms of the CLI world, what's happening right now? I mean, we are still getting patients coming in the ER with ulcers, you know, and we're certainly not treating claudicants right now. Rest pain, we're being very careful with. We started out a week ago a little more liberal with some of our patients, but because of resources and things, we're really getting a little bit worried about who can be treated and who shouldn't be. How are you guys approaching your CLI patients right now?
I mean, I think you bring up some really good points there too. Also, we too were pretty liberal. You know, we have a committee that essentially decides who's getting in the lab, for the most part, consisting of 4 individuals at our hospital. And essentially, if there's any question about whether or not the case needs to be done, it essentially all 4 of us have to agree. We have to have some level of consensus. But primarily the CLI patients, we're still obviously doing them. They need to be done. And obviously the morbidity is, and potential mortality is higher if we don't treat these patients quickly. Definitely the Rutherford 5 and 6s we're doing, but I do worry about our supply stream. You know, we do have issues with access to product, and I don't know if you guys are seeing this as well too. You know, I'm worried about deliveries, starting a case and not being able to finish it just because we don't have all the equipment that we need. So we do have to be very judicious in terms of which types of cases we take on. The Rutherford 4s, I think it's a case-by-case basis. Are they truly just on the cusp of opening up into a wound or whatnot too? I think some of these patients, you know, we call them rest pain when they're truly not rest pain. They're really more claudicants. So those are the patients that we really have to kind of screen appropriately.
Yeah, I would agree with that. You know, one of the things that we did very early on, I think actually almost 12, 13 days ago, is we sort of limited visitors within the hospital. That would include non-essential sales reps. So one of my concerns is you know, as we're cutting teams within the hospital, as we go to these A and B teams, and no one's coming in to check the inventory, are we going to fall short, even though we're decreasing the number of cases that we're doing? Are we going to fall short on the inventory that we have? And like you said, Jay, are we going to get in there, be doing a case, and then not have the tools that we need?
Yeah, one of the things that we're a little worried about too is the availability of blood products. So, you know, some of the cases we have to do emergently may require transfusion, and so we're really trying to weigh that out. And what we're seeing in our hospital is a little bit of a shift to ask for percutaneous procedures over other things, because the idea that maybe you can do it less invasively or with less, you know, blood loss, not necessarily endovascular, but other things too, like cholecystostomies and things like that, where I think people just are nervous about operating and really are looking for a way not to have to do these cases. So we're seeing a lot of stuff come towards us in that way that we do routinely, but not in the volumes that we're currently being asked to do. So I know there's a bunch of questions coming in, Frank. As we're going, please, I think you may have a list of them, or you're looking. If you want to bring some up now, we could take a couple-second pause, and then I think that maybe the next thing we should maybe launch into a little bit is about what we're doing with our office, telehealth, and phone consults and that type of thing. But why don't we, so we don't get stuck too far at the end, are there any questions you want to bring up now, Frank, that the audience is
Sure. I think one has to do with a variety of different things. It's from Malaysia, which I find interesting because I have a fellow that's works with us who's originally from Malaysia. But his concern is over the consent process, and do you have enough PPE to do the consent taking, and how are you doing it? I think that I've done some consent with telehealth for patients that I deemed to be essential. I saw them through the video. They'll basically, I think they're very, very low risk for having COVID. We have all sorts of criteria in place for not only once you have, we deemed you to be essential, but then you get a telephone interview to make sure that you're not having fevers, that you haven't been in any high risk areas, and you have not been around any sick people. Furthermore, we have in place now temperature checks or thermometer checks with a laser coming into the hospital. So if you have any, and this is even for the employees, including myself. So if you have any fever, you're going to get checked, and if you have it, then you're not going to be allowed to get in, and you'll probably get tested. So I think those are some of the things that we're doing right now to try to limit that exposure to those of us within the hospital.
Jay?
I think there's one other interesting question that sort of goes and can sort of be answered in a couple different ways. There was a question from Thomas Cardis, I think is how you say his last name, where they're instituting a rule. And I think, Jay, you sort of mentioned this, but how do you discriminate about which types of patients with CLI to do, and what are you doing in the OBL? It's tough for me to answer that question because I don't have an OBL. I have friends who have OBLs. What they have told me is they're sort of steering the patients towards the OBL and away from the hospital. I think that's certainly reasonable. I don't know what, and their fear is that they're going to progress so fast in the next 2 to 3 weeks that those patients would then require a longer, more difficult procedure and or hospitalization. I certainly think that the Rutherford 5 and 6 are patients that should be done. I have okayed those patients. I think anyone that requires a procedure that you feel needs to be done within the next 2 weeks is really a essential procedure and should be done. Now, again, as I said before, this could change tomorrow.
Right.
Yeah, Jay, what do you think of those comments?
No, I mean, I think that's absolutely correct. I mean, I've been out of the OBL for a few years, but I do have a number of colleagues who are there right now too. By and large, in our area, they're all shut down, and so most of these cases have shifted over to the hospital. Now, I can't speak to the physician-owned OBLs. Most of these are big corporate ones, and by and large, the operators there have brought that business into the hospital. So. I think that's one thing. These cases do need to be done. So I don't think there's any question as to whether or not if you have the ability to do them, you should do them. I think keeping them out of the hospital is wise. But again, the question also becomes, I mean, if you bring a COVID patient into your OBL, I mean, that could be disastrous as well too.
Yeah, I agree. And I think the comment Frank made that Jay seconded, I'd kind of third, which is, we're in a, at least in Miami, we're kind of approaching a real crisis, and we're looking at all our resources as others are. And we're trying to figure out what we can't do, but there are things that have to be done. And I think if you take a patient that, I think Frank's example was great, that you think absolutely has to be done in the next week or two, and they lay around a week, not much is going to happen, but they're going to get sicker and sicker, and they're going to end up in the hospital longer and longer. So our goal is to kind of get these patients done and get them out. The quicker we can get people out, the better we are. Frank, we're also doing those temperature screenings, and it's funny. A couple days ago, our chief medical officer, less than a week ago, said they recommend against wearing masks around the hospital and outside of the cath lab. Now they want everyone wearing them all the time. And so we're doing everything we can. And I think we're all doing this 1 mask a day kind of thing if we can. But it is again changing by the day, the way we're kind of approaching these things. So I have a feeling that the shortages, that a lot of what's being mandated isn't really about health, but it's more about our inventory and really what we have. So have either of you done any aneurysms since all this started?
No.
No.
Held off.
What I have set up for next week are some patients that require open surgical repair. So I have an open aorta femoral bypass, but the patient's got a severe rest pain, and I sort of feel like I have to do them. I can't put him out 2 weeks. The guy's up all night. He's on gabapentin and tramadol. He's starting to develop a small ulcer. So I think the elective, truly elective 5.5 centimeter aneurysms can truly wait. Those could probably wait 3 months. I've got a number of patients that are very high risk patients that I won't treat till you're 6 or 6.5. I've not had very many of those rupture on me, so I think it's safe. But I think that as time goes on and we've not had to deal with any sort of adverse events from waiting, that time will surely come. And I'm sure there'll be some headline news about someone who had to wait a little bit longer because of COVID. There were no beds, but it's a different time and a different place that we work in. So I do think that we have to weigh these risks and benefits. I was reading some results, not some results, but some statements from the president of the Society of Vascular Surgery for UK and Ireland. They actually recommended, or what I read was that maybe we should wait until it gets to 7 centimeters.
Oh.
We made a change to go to 6.5 if they were completely asymptomatic. I think that you could probably look at a few other radiographic findings that maybe a 6.5 is really big when the normal aorta is 18, but if their aorta is 29 or 30, you can probably wait a little bit longer. But I do think when you talk to people who are in New York City or Seattle, and they're in the sort of epicenters of this, their criteria are changing without them being able to really want to change them, but they just have no room to put the patients or to treat the patients. I personally would hold off on, if I had something that needed to be done, I'd hold off for 4 to 6 weeks if I could.
So there was another comment I saw from Kumar Rush, who is asking, I think, another question. We're talking about shortages of masks, shortages of respirators, blood, but as companies start to ramp down their productivity, has anyone found that it's hard to get device inventory? And we haven't seen that yet, but is anybody having problems restocking routine inventory in their department, catheters, stents, anything else? Does that come up for either of you guys?
I think the products from Asia, some of which have been restricted a little bit too. So we're starting to see some of that happen. The domestic product by and large has been okay. Most of our inventory issues have a lot to do with the reps not being allowed in the hospital and checking to make sure a product is getting reordered, because that's a constant issue that we have where, if the reps aren't there to help keep track of their product, then sometimes the product doesn't get reordered.
Yeah, exactly.
The other comment that I would say that's a change from the answer that I would have given yesterday is, as we've decided to go into teams, we work as a cardiologist, and inside that cardiologist, you got structural heart, you got an EP team, you got vascular teams, a lot of whom are sort of cross-trained, but some of them who are not. But as they go on to these teams, they sort of decide to sort of cross-pollinate a little bit. So that a whole EP team didn't go down. And I was asked what could industry do, and yesterday it was mainly about inventory. Now I think if industry could sort of put up some things on the web about how an EP cath lab team member could help someone with removing clot or coiling an aneurysm or treating an endovascular aneurysm, or treating an aneurysm with endovascular that they've never seen. But if they could quickly look at that and sort of educate themselves while they're on the bench, while they're on this sort of hot team in the hospital, I think that's something else that could be done, and it would be very helpful for not necessarily the physicians, but the providers that sort of help us get the job done.
Great point, Frank. So while we're talking about teams, let's ask this question. We talk about what all the physicians did, but what about the people working around you, your ARNPs, or I don't know if some of I'm certainly a good number of the 300 plus people on this webinar have, some of them have trainees, what are you doing about, you can go to shifts, so in our practice, in our hospital, when we go to shifts, obviously our income's going to go down this year. There's no question about it. That ends up being personal time off in a way. We're not going to be able to go take a ton of vacation in October if we've been out of work and down in income. But as physicians, we'll probably get by. But our ARNPs and things who make less, when they're not working, they may not be getting paid. And in our hospital, when employees get sent home, they're not necessarily paid during this time. Are your ARNPs, or your PAs, are they working full time? What about the people who don't want to lose money or give up their time? How are you managing that, guys?
Obviously, we have had to reduce the manpower within the lab itself too, and most of the staff members have been offered opportunities to work elsewhere in the hospital, so they kind of get their choices where they can go. And so there's always a room somewhere where they can help out. In terms of our ARMPs or PAs and whatnot too, we have primarily nurse practitioners. They're still working full time and they're still an integral part of the team, and we need their help in the hospital. So we have not told them to go home at this point.
Right?
It's a tough question. We had a discussion about that today. I think for right now, our system has been doing a very good job of maintaining salaries. We give them strong kudos for that right now. We have had to put our nurse practitioners and PAs also on teams, but you know, they're able to actually work from home just with the virtual clinics. We've got them sort of doing other jobs that we had a tough time instituting before because we were so busy. So things that we may not be able to build, but putting pathways in place. There was another comment about looking at the Coumadin clinic and trying to switch patients over to DOACs to try to limit the exposure there. So there are a lot of other things that we can do that aren't necessarily billable, but are better for the overall public health and better for the system that we have the time to do right now. So I think there are some things that we can do to fill in that place, but certainly it's not always bringing in income.
Right. It isn't, but a lot of people are very worried about that. For our trainees, by the way, if anyone has training programs, that's become a huge issue, and we've also put them on shifts and protected them, so we have half in, half out. And this isn't a question anyone can answer without trainees, but one of the things we're doing in our trainees, the ones that are home are basically chart rounding on everyone, and we've dramatically reduced the number of consults we're seeing on the floor. We're not going into rooms where there's febrile patients, or we're not going onto the wards where there's PUIs. The risk is too high to cross-contaminate because we're all over the hospital. So we're still seeing we're seeing every patient before they go into a procedure room down in our holding area. But as far as consults, we've reduced, and this is in terms of income, it's a huge issue for us, but we've reduced the number of consults we're doing dramatically. And we're doing a lot of rounding by chart. We actually have a dot phrase for our EMR saying that because of the coronavirus, this patient was rounded on by chart. We're calling the patients in their room and doing that type of thing. But are you guys doing anything like that?
We are, I mean, at least for our clinic visits, we have a special language that allows us to obviously note that this is a television. Obviously, the physical examination was deferred as a result. And that's
what about the in-hospital consults?
You know, my philosophy is, and we've had a lot of differing opinions on this. I do have some colleagues who really feel very strongly that you can't really diagnose a patient without laying hands on them. But the reality is, the vast majority of the things that we do can be accomplished virtually and don't necessarily require multiple people touching the patient, potentially increasing the risk of exposure. It's a difficult concept. I myself have tried to limit, especially in patients that could, even if it's a COVID rule out, definitely, we want to limit the number of people actually laying hands on the patient. Even though it does reduce your ability slightly, I think we are a little bit more reliant upon other types of diagnostic tests. Of course, the drawback there is you're potentially exposing other people to infection as well too. So I don't know that I have the right answer there too, but by and large, when it comes to a lot of these consultations that we're doing, we're trying to limit the exposure, try to do a lot more interviews at a distance. We have not yet employed things like iPad interactions and whatnot too, which some hospitals are doing as well. But you know, it depends on the area. I see that coming potentially within the next 2 weeks.
What about you, Frank?
I think vascular surgery is very well set to go full virtual. I've been trying to go virtual for a lot of my patients because I get a lot of patients from out of state, Tennessee, Georgia, South Carolina, and to have one, they can't afford the drive up and then the hotel stay if they have to stay. So I've been trying to go virtual all the time. The big problem I had, and I really had no problem FaceTiming someone, but it's a HIPAA violation. But now that violation has been lifted, I don't have any problem with that. I'm trying to limit the number of patients that we're seeing. I'd like it to get down to only the essential patients that we have to treat. Even the patients that we have to treat, I truly think we don't necessarily need to lay a hand on them. You have a TIA and you have a CTA with a 99% stenosis, I don't have to put my stethoscope right next to your mouth to determine that you have a bruit. Whether you have a bruit or not, you have a symptomatic lesion, high-grade stenosis, need an operation. I should be able to basically from 6 feet away discuss that operation with you and move on. I will say that most patients have been fine with this distance, this virtual visits. They understand the situations that they're in. They understand the need for our protection as well as theirs. Same with CLI. You got someone gets a CTA. They call us because the SFA and the popliteal is occluded and they've got rest pain. Patient needs an arteriogram and an intervention. There's some questions on here about endovascular versus open procedures. And there's a question from Malaysia as well about an 8-centimeter aneurysm. There's some questions about acute limb ischemia. I can tell you right now that as the only person on this panel who actually operates, not that you guys don't operate or you couldn't, but I would push all my surgeons to try to do endo first, to really try to, one, speed up the operation, prevent the intubations, and prevent that sort of aerosolization of the virus, because the problem with it is when you do that, you get very high loads of the virus released, and it puts us all, and I'm not talking about me, I'm talking about the anesthesiologist, I'm talking about every nurse in the room, every tech that's in the room. So our push is probably to go endo first over open procedures, unless we just deem endo's going to fail.
All right, so we've beat up the hospital pretty good, and we've touched a little bit on telemedicine. In our practice, there's a lot of different ways to do this, and they all seem to work. And CMS has gotten very liberal about this. So in our practice, we're doing telephone consults and billing the telephone codes, and we're doing live chat consults either with FaceTime or through an app we have on our phone, our billing app that allows us to basically FaceTime with patients. Doximetry has an excellent, very, very simple method of doing this. Our office is now, even the new patients, is 100% virtual. We're not bringing anybody in the office. Our office is in the hospital, so we really want to keep people out. But we're running a fairly full office. It's not full like it used to be, but it's fairly full. I thought it would be really light, just a couple patients in the morning or afternoon, but we're seeing a pretty large number. I'd say 2/3 of what we were doing. What about you guys? Are you using telemedicine, using the codes?
Yeah, right now we're going to be launching a Zoom type product for our telehealth consults. That should be running next week. We were supposed to go live this week. By and large, right now we're using the telephone style visits, and I would think that it's about 75% of our visits. It's hard to do with some of the new patients, but that being said, if they're willing to do it over the phone, we will try to do that. So we've really reduced the number of in-person visits. We still have a fair number, though. We have a massive number of patients coming to our office. You know, we have about 14 cardiologists within our group, and so there's a lot of patients being seen across 2 clinics, and it's a lot of throughput. But definitely, we've seen a significant reduction in the number of patients once we've moved to this, and I actually think it's a beneficial thing to offer consultations virtually. It potentially opens up more office hours. I mean, you could potentially see patients outside of the normal working hours, potentially even in the evenings. So I'm hopeful that these types of changes will continue to persist. long after the COVID outbreak, and we'll be able to continue to drive this as well.
I think this is really advanced medicine. I mean, it's a terrible pandemic, but there are some benefits out of it in the rapid change of regulations to allow us to go virtually in a relatively quick fashion. So I would appreciate. I'd just like to thank all those government organizations that have made those changes quickly, as well as the insurers. One comment that I would like to make to you, Jim, is it's easy enough for us to go virtual, but one of my concerns is not just for myself, but for our technicians, and that would be and I know you have a great passion for it, is the vascular lab. So how do you determine who gets a vascular lab procedure, and how do you keep those individuals safe? Because they are in very close contact with patients, especially when you're taking a look at carotids, ABIs, aneurysms. What are you doing in those situations?
Frank, that's a great question, and we've been dealing with that a lot, and our non-invasive lab techs are frightened. In fact, just as a quick story, one was called to the ICU on a COVID positive patient, and everyone in the ICU, the nurses were all donned up properly, and she hadn't been through the training, and she panicked. She didn't know how to go in the room, and they were yelling at her to get in the room and this type of thing. So in our hospital, there are so many inappropriate non-invasive tests ordered. And to be honest, we end up doing a lot of them. We just can't fight that fight constantly. Well, now, as Jay pointed out, there's going to be some good things that come out of this. And one of the good things now is we're not doing a venous study on everybody in the ER who has leg pain. They have to have some real criteria. We're not doing carotid duplexes on patients who really don't need them. So we've limited, we've really tightened up the indications, and we're not doing the unnecessary studies. And we've actually created for PUI and COVID positive patients modified exams. So as you know, with DVT, we're doing 2-point compression versus full duplex. Not quite as good, but not bad. In the vascular lab, we're not doing full duplex exams. We're getting ABIs to start. If the ABI is above 0.8, we're not finishing the exam unless there's some dramatic reason that that the reader or medical director approves. So we've created a few limited exams to shorten exposure time, and we're really trying to crack down on the unnecessary tests. What about you guys?
So, we have not necessarily truncated the examinations, but rather, as Frank mentioned, cut down on the number of examinations being done and delaying a lot of these studies. So a lot of the routine surveillance things, most of our patients are getting 3 and 6 month surveillance studies. A lot of those are getting pushed out, and so we're having to it's a lot of work, but go through each of these patients to find out, do they really need to have their study done right away? Actually, I'll kind of ask this question to the rest of you as well too. We're obviously involved in a lot of studies as well too, and a lot of these studies do require some type of surveillance work, especially with duplex and whatnot too. Several of the BTK studies, for example. I've by and large been telling our staff to go ahead and do those so that we're not ending up with protocol deviations. What are you guys doing?
We're trying to honor our research commitments, but our outpatients that are coming in for routine follow-up that aren't in research studies, they're all being pushed back. The 3-month follow-ups to 6 months or 6 months to a year. Unless there's an acute problem, we're pushing everyone back. What about you, Frank?
Same. For those patients that were under just routine surveillance, what I'm asking my team to do is just continue with the telehealth visit. If they are not having any change in symptoms and we've been following them, I just have asked them to reschedule them, whatever routine surveillance they were on. Because again, when you take a look at what we're scheduling, we're for the most part only treating patients that are bleeding. They have something that's truly ischemic, or they're symptomatic from their lesion. So if you're in an outpatient surveillance and you don't have any change, I say just document that telehealth visit, document the pandemic that we're under, and then reschedule them for routine surveillance and call back if they have any changes. And most of those patients know what those changes are. A couple other questions here that I think are that are actually quite interesting. I'll answer one real quick, but I'm going to ask both questions. First one is, what's happening to your varicose vein practice during this time? We shut ours down. We just shut it off. One, because we thought our physicians were going to be too close. Our physician that does it actually has asthma, so she was quite concerned about doing them. They're actually in pretty close contact to a lot of these patients that you're treating. They can be sort of long procedures as well if you're doing a lot of phlebectomies. The other one is, what's your process when you go home at night to keep your family exposure limited? And do you stay away from the family in a hotel, apartment, or anything else? Jim, Jay?
Is that before or after the COVID virus? Jay, go ahead.
Well, it actually changed as of today, but for the last 2 weeks, I've been isolated to one side of the house. The moment I enter the house, I was taking my shoes off and stripping before I even got into the home, and then going right to the shower, showering up, and then coming out. But I have not touched my wife or my kids in about 2 weeks. And today I got an apartment, so I'm moving out for the next 6 months. So my wife is immunocompromised. She's on Humira. And so I have to take really extreme precautions. I cannot let her get infected. And, I got 2 kids at home that are homeschooling right now too, 1 kid out of the house. So, obviously there's a lot at stake. So I made the decision, kind of a tough one, to move out, but it's probably the right thing to do.
I haven't, my wife's actually quarantined to the home now, so we're on different sides of the house. We can't eat together until her tests come back. I do come home. I don't wear my shoes. I don't wear my shoes out of the hospital from work, but I change. But as soon as I get home, I basically strip down, get in the shower. I bought some new towel. Everything I bathe with is white, so I bleach and wash my towels every night. We're rigorous about wiping down. Like, I have wipes in my car. I have hand sanitizer in my car. We sanitize the office when we come in, our office space. We sanitize several times a day when we're leaving. And, it's tough with groceries and things like that. Basically, we have a combination of either getting out to the supermarket or having stuff shipped in, Instacart, or some different meal services. Everything's left outside. We take it, we wipe it down, we bring it in. I usually cook, help my wife out because she can't get in the kitchen, but it's been it is kind of a tough situation. And I think we are in high risk. And I think we should all recognize, when you really look at what's going on, physicians are at a much higher risk for more severe disease, it seems like, than the general public. And we see, like, we have an interventional cardiologist right now in critical condition in our ICU with COVID. We have, you see it all over the world. Physicians die, are either dying or very sick. So I think this aerosolization, this closeness, is something we need to be careful about for ourselves and critical about with our family members.
Yeah, I'm going to get a big "I told you so" from my wife when I get home. Maybe watching this, I don't know. But we've been instructed now to only wear scrubs back and forth to the hospital as much as possible. We've been instructed to take our shoes off before we get home. And basically, as Jay said, to then immediately shower. So I'll start doing those things. The one thing, though, is this week I've been on that bench, so I haven't been in and out of the hospital. I'm in my office right now, but no patient contact.
Yeah, so I'm back at work, and I think everyone on this webinar knows we talk about all this, but it's real easy on the way out the door just to hit the door handle with your hand, and then, well, what can you do, or to do something. So it doesn't take much. You do everything right in one little screw up. So, and it's hard to know how far to go. So I think it's a really tough time. Hopefully we'll all manage through this and go. Frank, other questions that are on there? Otherwise we can ask some.
One other question I think is a reasonable question. I've not had any issues with this, or I haven't heard. but patients having problems getting their medicines due to samples not being available and or loss of employment. What are you guys hearing?
Well, we've had we've had a number of people worrying about prices. I'll tell you what, I don't know if it's going to work or not, but one of the drugs, Plaquenil, hydroxychloroquine, is simply not available from CVS, Walgreens, or any of the online pharmacies here in Miami. So the people who have been diagnosed or wanted to be started on that earlier with a prescription from a physician can't get it. That stuff's all been written for and hoarded by people stocking up on their own or trying to get it, docs writing it early on and stockpiling it. So that's the one medicine I know in Miami you simply can't get. Whether it's going to help or not, I don't know, but you can't get it.
Yeah, I mean, we were fortunate that that a lot of the reps in our community were able to get us samples early on, but obviously those stocks are going to run low, and we're not having reps come back to the office at all to resupply. So there is going to be a very realistic concern, especially with the anticoagulants. Those are the ones that we've typically given out samples for. So we may have to switch patients over to warfarin and whatnot too. And another issue though with warfarin, and I don't know if you guys have seen this or not, we have had multiple patients who can't get tests done. They can't get their INRs checked. So we've actually had to do the opposite and put them temporarily on Xarelto or Eliquis or whatnot, just until they can start getting tests done again too, which is crazy. But it's going to be a kind of a catch-22 situation, I think.
I think we're running out of time a little bit. There's one last question that I'll answer, and I'll ask the other two of you. But the last question is, how are you keeping fit? What alternatives to playing basketball, Dr. Benenati? I will say that I do two things to stay in shape. One is run, the other one's ride a bike, both of which I prefer to do alone. So I'm okay. But Jim, as a basketball player, I mean, are you just playing a little just one versus one, the other one being yourself, or your imaginary friend from when you were 6 years old?
To be honest, for me, the mental health part of this exercise is mandatory. So I'm trying to, I can't say every day, but 5 times a week, I'm doing stuff. I have do stuff here at home, outside, because we have great weather right now. So I have a little circuit I've set up. I do stuff. I do yoga a couple times a week. But for those basketball players, I do have a little hoop. I do have a court at my house, and I shoot on average of 100 free throws every single night that I go out to do that. And so I am doing that, trying to get 100 free throws in a night. So
how many do you make?
3 or 4. So, listen, I think we probably are running out of time. I think this was really helpful. It was helpful for me. I'm sure, I think Frank and Jay are fantastic, and your insight's been helpful. Maybe I'd also like to take a moment and thank Penumbra for sponsoring this. This had nothing to do with any of their products or anything they're doing, but they were nice enough to do this. Maybe if this keeps going on, we can revisit and do this again in a month, because it will be a different world. A lot will be changing. This is obviously an event that's going to define us professionally for the rest of our lives. So we have to really do our best here. And I'll let Jay and Frank say a word, but I just on behalf of everyone that helped put this on, I want to thank you and all those that are listening. I wish you all the best and all the best of health. Frank or Jay?
I just want to say it's good to see all you guys. I actually miss the meetings in some ways, because it's a chance to just hang out with everybody, even the peer meetings and whatnot too. There's something to be said about live interaction, but the webinar format is probably the new world for the near future. But I do just want to say I look forward to seeing all you guys again live in person sometime soon.
I don't have much to add other than I'd like to just tell everyone to stay safe, stay as far away from as many people as you can for the short time being, and then I think we will get through this at some point. But I certainly hope so. But I'd like to thank Penumbra as well for getting us all together, because I certainly learned a lot as well.
All right, guys, this is fantastic. Thanks to everyone, and thanks for all you who are listening. And we wish everyone the safest and best of times coming up. Thank you.
Appreciate it. Thank you.